Hello, my name is Alexandria Armak, and I'm currently in the Master of Health Administration program. This presentation today is going to be on chronic disease management in the United States. This presentation will cover key goals with chronic disease management, abbreviated as CDM for the rest of the presentation. It will also cover driving forces of CDM, roles of healthcare professionals, two models of CDM, and the financial impact. Chronic disease management was created to ultimately reduce healthcare costs for those with chronic diseases while improving their quality of life. CDM is a preventative and proactive form of care in hopes to minimize the effects of the disease. Most chronic diseases are difficult to manage and cannot be fully treated with medication alone. That is a reason why one goal of chronic disease management is to empower individuals with self-care. Making the patients a part of the healthcare team alongside the provider helps prevent complications. Creating this relationship with the healthcare team, the individual shouldn't have to deal with over or underuse of medical care they need, saving them and the healthcare system money. It is easy to see the driving forces of chronic disease management after discussing the goals. Looking at statistics from Thompson and others in 2020 and Barden and others in 2020, more than 140 million Americans live with one or more chronic disease. In addition, more than 2/3 of deaths in the U.S. are from CD. Those two statistics alone show why chronic disease consumes 86% of healthcare costs. According to Thompson and others in 2020, most diagnoses are irreversible. If they are irreversible, how does the U.S. healthcare system decrease these stats? Chronic disease management focuses on prevention and proactive measures. In one scenario, we could have a patient that has symptoms of chronic disease, but no diagnosis yet. These programs can help with early intervention and hopefully slowing the progress of the disease. On the other hand, we could have a patient that has had the known chronic disease for years. The CDM programs can give them the motivation to keep fighting and using self-care interventions at home. This would hopefully keep their symptoms from progressing and they wouldn't have to get more expensive treatments. Some main internal clinical roles include primary care physicians, specialists, depending on what the chronic disease is, nurses, pharmacists, and social workers. The role of the PCP in CDM is to understand your total health and refer you to the correct specialist when presenting with symptoms of a CD. A PCP knows your entire health history throughout your life and knows your family's as well. They should have a close bond with you compared to other healthcare professionals, and they should be an advocate for you and your medical care team. The specialist one sees for a CD differs depending on their disorder. The specialist is the individual the patient has checkup appointments with to go over their symptoms and how they are handling treatment. The nurse's largest role in CDM is patient education. The patient needs to be invested in their health, and a nurse's education can help patients understand their treatments better in a way that makes sense to them. The pharmacist is crucial for CDM because they help make sure there's optimal use of patients' medications. They track the patient's medical record and their history of prescriptions and make sure their current therapies are compliant. Finally, social workers can help identify and overcome factors that may be impacting a CD patient's overall health. They can figure out if there are issues at home, poor health literacy, or social isolation that can contribute to their management of CD. For non-clinical roles, this can include epidemiologists, Department of Agriculture, patients, family, and the community. Epidemiologists are important for chronic care management because they focus on measuring how many Americans have chronic diseases. According to the Centers for Disease Control and Prevention in 2021, the data they collect helps them understand how chronic diseases affect Americans and how resources can be given for prevention and control. I mentioned the Department of Agriculture for cities to control chronic diseases because a healthy environment supports healthy behaviors. Some examples include passing smoke-free air laws, banning artificial trans fats from food supplies, etc. I would argue that the most important healthcare professional in CDM is the patient. Healthcare professionals can provide resources for those with CD, but they are only useful if the patient wants to improve their health. The CDC has self-management education programs that help individuals learn skills to manage their symptoms and improve their overall health. Families could do these courses with the patients, giving them support, letting them know they are not alone. Having community resources is great for CD management because it encourages individuals to improve their quality of life. I will be looking at the Stanford and chronic care models for CDM programs. First, Stanford is a self-management model, and it is designed to be disseminated in communities. It is also cost-effective and not disease-specific. The delivery system is through community workshops or an online format. The workshops are 6 weeks long and they are facilitated by highly trained lay leaders. This model really focuses on covering self-management skills and is self-directed learning. The training is evidence-based, consisting of clinical information. It is important that this model is led by lay people with chronic conditions because they can connect with the individuals more than healthcare professionals can. Every person with a CD has different symptoms and conditions, even if they have the same diagnosis. This model has reduced the number of hospitalizations and ER visits. After taking out the cost of the program, on average, each person saves around $400 in hospital utilization. On the other side of the spectrum is the chronic care model. This is a different approach to a CDM model when looking at the Stanford model. The Stanford model was focused on self-management skills for patients with CD and was led by lay people with CD. The chronic care model is a guide for change. It is an evidence-based model as well, being developed and tested with a quality improvement approach. This model is a visual guide that includes the integrated reorganization of care delivery that is needed to improve patient outcomes. In comparison, this model focuses on community resources and policies, health system organizations, self-management support, delivery system design, decision support, and clinical information systems. Instead of just focusing on the patient and their own self-management skills, this model focuses on the informed and activated patient and their relationship with the proactive healthcare team. This toolkit is designed for healthcare systems more than the patient. Health organizations can use this model to focus on keeping the patient in the center of every decision. This model can help healthcare organizations financially. Depending on the track they use with this toolkit, there are reimbursements when using it, and it is up to the organization to decide which track is right for them. When looking at the financial impact of chronic diseases, it is important to look at the cost the U.S. is losing per year and then compare it to how much CDM would be. Even though management can be expensive as well, overall, it should lower hospitalization and the medication utilization. In addition, the CDC measures the cost compared to the years of life gained if these management strategies are used. For example, heart disease and stroke cost the U.S. around $216 billion each year. It also makes up 1/3 of all U.S. deaths. If team-based care management is used, there are $9,716 to $13,992 per quality adjusted life year gained. Looking at diabetes, there are around 34.2 million Americans who live with this disease, and it costs us $327 billion per year. If the management of an intensive lifestyle modification is used, there is $12,500 per quality adjusted life year gained. In conclusion, CDM programs are focused on improving the quality of life for individuals while reducing healthcare costs. In addition, they empower individuals with self-care at home. The management also helps with early intervention before the disease progresses. It is important to understand that non-clinical roles are just as important as clinical. When comparing CDM models, the organization and individuals must decide which one works best for them. Looking at the financial impacts, quality of life gained back should be the main focus. Here is the beginning of my references. The references also carry on slide 12 and 13. I just want to thank everybody for listening to my presentation. If you have any questions, just leave them in the comments.